it occurs to me one other thing that you haven't mentioned is folks who have had some heart failure, have been on medications, and come in with an exacerbation. And again, you're going to work up the etiology of that, but isn't part of the exacerbation potentially reviewing the meds they're on? And whether those are the best meds and whether they're following through and taking them?
Or yeah, whether they're even on those medications is a question that needs to be addressed right away.
This is the old medicine reconciliation moment, right? That was addressed. By the way, I can remember when it was first presented to us. And everybody said, oh, we don't have to do that. We know what they're taking. Lo and behold, look at his face. He's agreeing. We didn't.
True.
We didn't. They didn't know what they were taking. We knew what they were supposed to be taking. There's a big difference. How do you get at that? How do you take a patient who has medicines that you think they're taking and actually ascertain whether they're taking them and how much? That's a tough thing to do, isn't it?
Right. I mean, you have to rely on the patient's own past history. You have to rely on family members to help fill in the gaps. But ideally, medication reconciliation is lining the indication with the medication. And you'd be surprised, I mean, so many patients will be coming into the hospital on PPIs and have absolutely no indication. And so that's what the process is all about, is just discontinuing those in which the patient doesn't need anymore, and then adding those in which the patient does need.
So it would seem to me that one thing you have to do is, are they taking the medicines that we think they're taking in the first place? And then don't you have to assess, gee, are those the right meds in the first place at all? I mean, did we give the right prescription? Did somebody else actually start out on the right cocktail? Is that fair?
And that is a lot of times the toughest part, is figuring out exactly what they're taking, because they may not know to tell you exactly what they're taking, or even know some of the medications what they're for. So one approach is to have them go to their medicine cabinet, take all of their bottles, stick them in a bag, bring them into clinic or the hospital, and then we can look and see exactly bottle by bottle, are you taking this, half a tablet, full tablet, what exactly is the patient doing?
And I think a piece of that is not just the things that we gave them, right? Because a lot of people take medicines that aren't prescribed by physicians, that they've decided that might be helpful for traditional medicine reasons or for holistic reasons. And supplements people don't think of as medications. We don't ask about those often. And some of those might actually make heart failure worse.
Exactly.
And then things we use over the counter, a classic example are non-steroidal anti-inflammatory drugs can actually make heart failure worse too. So drugs like ibuprofen or naproxen, these are medicines that if you have severe heart failure, you probably don't want to be taking a lot of them because they might make you hold on to fluid.
And patients might think that that is Tylenol.
Yeah.
That is the same thing, and
Yeah.
they may not realize the difference and say they're taking Tylenol when they're taking an NSAID.
I mean, when I see a patient come in with a bag like that, I just say, thank you. I mean, yes, you're going to have to go through this, but thank you. Or they come in with a very detailed list that their daughter, son, wife, husband has actually made up and typed or handwritten, but something where they're keeping track. It's really tough out there. I have a sense also that there are over-the-counter medicines, not just the NSAIDs, that are being pushed on television and in the health food stores that people are taking, and they're not even aware they should be telling you about. You know, I mean, do you see that?
We see it all the time. I think there is and often physicians, because of time in the clinic setting, this is where I think it's really helpful to have a multidisciplinary team, because in a 15-minute clinic encounter, what the patient initially tells you is sort of what most people go by, and I think you need to deliberately ask, are you taking supplements, are you taking vitamins, are you taking things that I haven't given you as part of your daily routine? Because a lot of these things do contain substances that may make heart failure worse.
I mean, we see it all the time pre-op. You were going to say something.
I was going to say that patients may take things that they don't even realize that they think are inert for cough and cold. They have an upper respiratory infection. They take something that has a decongestant in it, not so great in a heart failure setting,
Okay.
and may not realize that that is bad.
Again, can we do a better job? Could we be in our heart failure patients before we send them home, or if they're at home, at least give them a piece of paper and give them a bullet point list of, here are some of the real big offenders, please stay away from them? Isn't that our job too?
Definitely, and we do that actually as part of planning for discharge, if you wanted to segue into that topic.
Well, we can do that too, but I see this every day. I see people who are trying to do their best. I don't think anybody's trying to get sick. And they're trying to do the right thing and take the right meds, and they come in on cocktails that make your head explode, or in this case, your heart explode.